So, if you break your arm, right, an X-ray gives you a pretty clean binary answer.
Right, yeah, a jagged white line on a black background.
Exactly. The doctor points to it, puts a cast on it, and well, you're done. But what happens when cancer invades, the most complex, crowded, and emotionally vital real estate on your body, like your face?
The binary simplicity just completely disappears.
It really does. You are suddenly looking at this diagnostic and surgical landscape that is incredibly murky and, astonishingly high stakes. So today we are opening a highly detailed surgical text. It's titled Surgical Resection of Cancer of the Buccal Mucosa by Devendra Chakar and Mitali Dandekar.
Yeah, it's a fascinating paper.
It is. And the mission of this deep dive is to take you, the listener, step by step through exactly how surgical teams navigate this delicate three-dimensional puzzle of the human head and neck. Because, the goal isn't just surviving the cancer.
Right, the goal is preserving a patient's fundamental ability to eat, to speak, and honestly to look like themselves when they wake up.
Yeah, which is just a monumental task. So to start us off, the focus of this text is the buccal mucosa, which is basically the medical term for the inner lining of your cheek.
Exactly, yeah. And to give you some context on why this specific text even exists, we kind of have to look at global epidemiology.
Okay.
Because in North America and Western Europe, cancers of the inner cheek are actually relatively rare. They account for maybe, 5 to 10% of oral cavity cancer.
Which isn't a lot.
No, not at all. But if you flip the map to the South Asian subcontinent, the numbers are staggeringly different. It is a dominant, highly common malignancy over there.
And see, I always tend to assume massive geographical discrepancies like that are tied to, environmental factors or maybe genetics.
Sure, that makes sense.
But the text points directly to regional habits, specifically chewing tobacco, betel quid, and betel nut. So, I'm assuming this is just a prolonged chemical exposure issue?
Well, the chemical exposure is massive, yeah, but it is actually a dual assault. It's mechanical and chemical.
Oh, really? Mechanical too?
Yeah, so people who consume betel quid often tuck it into the cheek pouch and just leave it there for hours at a time. And the betel nut itself is really fibrous and rough.
Like sandpaper almost.
Basically, yeah. Over years, the constant mechanical friction of holding and chewing that coarse material continuously abrades and wears down the delicate mucosal barrier of the inner cheek.
Ouch. That sounds awful.
It is, and simultaneously, you are bathing those microabrasions in potent chemical alkaloids and carcinogens from the tobacco and the nut.
So it's just a constant cycle of damage.
Exactly. It creates a localized environment of chronic inflammation and constant cellular repair, which, as we know, is the perfect breeding ground for a tumor.
Right. So the barrier breaks down over time, allowing the cancer to take root. Now, before a surgeon can even think about making a cut to remove one of these tumors, they have to completely understand the neighborhood they're operating in.
Oh, absolutely. And it is dense.
Yeah, looking at the anatomy described in this text, it's wild. Like if you run your tongue along your inner cheek right now, it feels pretty simple. Just a wall of soft tissue.
Right. But the text maps out something called the gingivobuccal complex.
Okay, let's unpack this. What exactly is that?
Well, it helps to visualize the boundaries. That inner cheek is bordered at the top and bottom by your upper and lower alveolus.
Which is the medical term for the gums, right?
Yeah, the gums and the bone holding your teeth. And if you slide your tongue all the way to the back of your gums, right behind your very last wisdom tooth, you hit a small pad of tissue called the retromolar trigone.
Okay.
So that entire pocket, all of that is the gingivocal complex. But the real danger here isn't the surface tissue you can feel with your tongue.
It's what's underneath.
Exactly. It's what lies directly beneath it. Because right behind the inner cheek is the buccinator muscle, which is what you use to, blow out a candle or chew food.
Right.
Pass through that, and you enter the masticator space.
Sounds intense.
It is. It's a cavity housing the incredibly powerful muscles that operate your jaw. Go deeper still, and you hit the infratemporal fossa, or ITF, which is a hidden complex cavity packed right at the base of the skull.
I'm picturing this like trying to do major construction in a crowded city electrical grid.
That's a great way to look at it.
Like, you can't just dig a hole without worrying about severing a major power line. Things like the facial artery or the trigeminal nerve, which gives you face sensation. But, I'm stuck on how the cancer actually moves through all this.
How do you mean?
Well, I've always pictured tumors growing outward, like a balloon slowly inflating. If a tumor starts on that inner cheek, how is it getting all the way deep into the base of the skull?
Yeah. See, tumors in this region do not behave like balloons. They infiltrate.
Okay.
Yeah. The fascial planes, which are the thin layers of connective tissue that wrap around these deep facial muscles, they act like anatomical highways or like water channels. So cancer cells follow the path of least resistance. Instead of pushing outward, they slide along those slippery fascial planes directly into the deep muscular spaces.
That is terrifying.
It really is. And they also hijack the lymphatic system. The text specifically flags level IB, which are the submandibular lymph nodes right under your jawline.
So under the chin, basically.
Right. That is the primary landing zone, basically the first echelon, where tumor cells will travel once they breach the local tissue.
So this radically changes the surgical approach, I'd imagine.
Completely. You aren't just scraping a lesion off the surface anymore. You are cracking a stealth invasion deep into the musculature of the skull.
Which means the surgeons are flying blind without a map. Because, if these tumors are tunneling into hidden spaces, the pre-op imaging has to be flawless.
It has to be perfect.
Yeah, and the text describes a mapping technique that completely caught me off guard. The puffed cheek technique. I read that and couldn't quite wrap my head around how trapping air in your mouth helps a high-tech CT scan.
It sounds a bit silly, but it is an incredibly elegant solution to a physical problem.
How so?
Well, when a patient gets a contrast-enhanced computed tomography scan, a CECT scan, to map the soft tissues, the radiology team literally instructs them to puff out their cheeks like a blowfish and hold that air during the scan.
Literally puffing them out.
Yeah, literally. Because without that pocket of air, the inner cheek rests naturally against the gums and teeth. On a scan, all of those soft tissues compress together into a solid, indistinguishable mass of gray pixels.
Oh, I see. So the surgeon can't tell where the healthy gum ends and the cancerous cheek begins.
Exactly. By puffing the cheeks, the trapped air physically separates the inner cheek from the gums, and air shows up as stark black on the scan, providing an artificial boundary layer.
That's brilliant.
It gives surgeons a crystal clear, high-resolution view of the tumor's exact borders, thickness, and depth.
Just a pocket of trapped air completely revolutionizes the surgical map. But mapping the soft tissue tunnels is only half the battle, right? They also have to figure out if the cancer has chewed into the jawbone itself.
Yes, bone invasion is a massive concern.
The text brings up standard dental x-rays like the orthopentagram or OPG, with machine spins around your head. It's pretty critical of them. It says an OPG won't even register bone damage until the patient has lost up to 30% of their bone cortex.
Yeah, that's a major limitation.
Why on earth does a third of the bone have to be missing before an x-ray catches it?
It really comes down to limitations of two-dimensional imaging. An OPG takes a three-dimensional, curved, highly dense jawbone and flattens it into a 2D image.
Right, okay.
The outer layer of your jawbone, the cortex, is incredibly dense and calcified. It acts like a visual shield. Even if the tumor has severely eroded the softer inner bone, that dense outer cortex overlapping on the 2D image masks the obstruction. So 30% of the bone has to be physically eaten away before the loss of density is significant enough right through the cortex to show up on the film.
Which is way too late if you are planning millimeter-precise surgery.
Far too late, yeah. That is why the CECT scan is the gold standard. It takes thin, 3D slices of the bone, allowing surgeons to see pinpoint cortical erosions.
But wait, you might wonder why they don't just use an MRI, since MRIs are notoriously excellent for viewing soft tissue.
You'd think so, but the text notes a specific quirk with MRIs in this context. They actually tend to overestimate bone involvement.
Oh, really? How?
Due to dental artifacts and marrow edema, they show inflammation as tumor invasion. So the CT scan remains the definitive tool for the jawbone.
So all of this pre-op mapping, the puff cheeks and the 3D bone slices, it's all building toward a single terrifying question for the patient, right? Is this cancer resectable? Meaning, can surgery actually fix this?
That is the ultimate question, yes.
And looking at the criteria for when a cancer becomes irresectable when surgery is just completely off the table. The margins are devastatingly thin. A tiny bit of upward growth seems to be the difference between a curative surgery and, well, palliative care.
The line is absolute, and it revolves around a specific anatomical landmark called the sigmoid notch.
The sigmoid notch.
Yeah, if you picture a jawbone, the mandible, there is a U-shaped dip near the back hinge where it connects to the skull. That is the sigmoid notch.
Okay, I can picture that.
Surgeons draw a horizontal line on the CT scan right across that notch. If the tumor has grown above that line into the high infratemporal fossa we discussed earlier, complete removal becomes virtually impossible.
Because at that height, it's essentially reached the skull base.
Precisely. Once it crosses that threshold, the cancer has access to tiny anatomical fissures in the skull, passageways like the inferior orbital fissure near the eye or the pterygomaxillary fissure. It is no longer contained within a resectable compartment. It can scatter. Furthermore, if the tumor has wrapped itself around the internal carotid artery or tracked along the trigeminal nerve directly up to the brain base, attempting to cut it out would cause catastrophic, fatal bleeding or brain damage.
Wow. At that point, the cancer has just won the anatomical arms race.
Sadly, yes.
But let's say the tumor stays below that notch. The scans show clear margins. The surgery is a go. So the anesthesiologist steps up to put the patient under and immediately hits a brick wall.
Yeah, the airway challenge.
Right. The text outlines an airway challenge before a single surgical cut is even made.
The physical reality of these tumors presents an immediate crisis called trismus, commonly known as lockjaw. We talked about tumors invading the masticator space, those deep chewing muscles.
Right.
When cancer infiltrates those muscles or causes intense nerve spasms, it effectively welds the jaw shut. The patient physically cannot open their mouth.
Which is a huge problem for anesthesia.
A massive problem. A standard intubation, where an anesthesiologist looks down the throat to place a breathing tube, requires the mouth to open widely.
And if the jaw is locked, forcing it open could cause, like, a lethal airway trauma or fracture.
Well, it is entirely unsafe. So the surgical team must bypass the mouth altogether. They typically perform an awake fiber optic intubation.
That sounds rough.
They numb the patient's nasal passage, and while the patient is still conscious and breathing on their own, carefully thread a tiny camera and breathing tube through the nose and down into the windpipe.
Wow. And if they can't do that?
If the tumor is obstructing the throat too severely for even that, they move to a temporary tracheostomy, making an incision directly into the windpipe at the base of the neck to establish a secure airway. Only after the airway is locked down can they administer the general anesthesia.
Okay, so the anesthesiologist has successfully bypassed a locked jaw, but that locked jaw is a glaring reminder of the surgical problem. The jawbone itself is in the way.
It is literally blocking the door.
Right. How do you get a tumor out of the inner cheek when it's caged in by bone? For very small tumors near the front, they can use a peroral approach, working entirely through the open mouth. But for most buccal mucosa cancers, they need massive access,
They have to do a cheek flap.
which is effectively peeling back the face. And the text focuses on two main incisions to do this: midline lip split and the angle split. I was looking at these diagrams and I was confused by the logic.
How so?
Well, if a tumor is located near the corner of the mouth, my instinct says you make the shortest possible cut, an angle split, right at the corner. Why would a surgeon ever choose to cut straight down the center of the chin, far away from the tumor, for a midline split?
It's a great question, and your instinct touches on a masterclass in vascular logic.
Muscular logic, yeah.
The choice of incision is entirely dictated by how blood flows through the human face. Your lips are fed by the superior and inferior labial arteries. These blood vessels travel horizontally, coming in from the far left and right sides of your face, and they meet in the middle of your lips. Let's say the tumor is near the right corner of your mouth.
Okay.
If the surgeon decides to do a midline split, cutting straight down the center of your chin, they have just severed the arterial blood supply coming from the left side. Then they go to remove the tumor on the right side, cutting the tissue there.
Wait, I see it. You just cut the left supply with the chin split, and the right supply by removing the tumor.
Exactly. You have completely isolated the intervening piece of the lip. It has no blood supply whatsoever.
Oh, wow.
That section of tissue will necrotize and die on the patient's face because the surgeon failed to respect the vascular map. It's like cutting off the water main at both ends of a street. Every house in between goes dry.
That makes total sense.
So for tumors near the corner, surgeons perform the angle split at the corner itself, preserving the entire cross-facial blood flow from the opposite side.
But what if the tumor's further back?
If the tumor is located further back, deeper in the cheek toward the molars, the midline lip split is strongly preferred. It provides much better access to the back of the jaw, and because it divides the lip cleanly at its natural midpoint, it preserves better oral competence once healed.
Oral competence meaning, like, keeping food in.
Right, meaning the patient retains the muscle control to keep food and liquids in their mouth.
Okay, so the cheek flap is open, folded back like a page in a book. The soft tissue is exposed. But almost immediately, they hit the hardest obstacle in the human face: the mandible, the bone.
Yeah, the tough membrane covering the bone, the periosteum, acts as a temporary barrier. But cancer is relentless. It typically breaks into the jawbone through the path of least resistance.
Where does that usually happen?
Usually this happens at the weak points of our oral anatomy. It invades through the occlusal surface, the flat top of the bone where your teeth actually sit, or through the point of abutment, which is the exact crease where your soft inner cheek tissue folds down and attaches to your hard gums.
So what does this all mean for the surgeon? I read that if the tumor is just superficial, resting on the surface, the surgeons perform a marginal mandibulectomy.
Right.
So they don't take the whole jaw, they just shave off the affected part of the bone, horizontally or vertically. But looking at the rules for these stone cuts, I have a major question.
Sure, go ahead.
The text mandates making canoe cuts. If I am a surgeon trying to guarantee I got all the microscopic cancer cells out of a bone, wouldn't a straight 90-degree square cut with an oscillating surgical saw be the most efficient, cleanest way to ensure clear margins? Why take the time to sculpt a canoe shape?
From a purely geometrical standpoint of removing tissue, a square might make sense. But from a physics standpoint, a 90-degree square cut is a catastrophic error.
Really, a catastrophic error.
Yeah. If you clench your jaw right now, you can feel that intense pressure. Human jaws exert an incredible amount of mechanical force to grind food. If a surgeon cuts a perfect sharp square into the mandible, those 90-degree internal corners become extreme stress points.
Oh, I see where this is going.
The very next time the patient tries to bite down on a tough piece of food, the physical stress of the jaw muscles will concentrate violently at those sharp corners, practically guaranteeing a devastating bone fracture.
The structural integrity of the jaw just snaps.
Precisely. By curving the edges to create a gentle, sloping canoe shape, the surgeon ensures the mechanical stress of chewing is distributed evenly across the remaining bone structure.
That's fascinating engineering.
Furthermore, the text strictly enforces the 1 centimeter rule. After making these canoe cuts, surgeons must leave an intact, continuous bridge of bone along the bottom edge of the jaw that is at least 1 centimeter thick.
Yeah, they don't.
Any thinner than that, and the bone simply cannot support the functional load of the facial muscles and will fracture under its own operational weight.
But what if the cancer doesn't respect the 1 centimeter rule? What if it's eaten so deep into the marrow that a canoe cut is impossible?
Then marginal shaving is abandoned. The surgical team must pivot to a segmental or hemimandibulectomy.
Which sounds intense.
It involves taking medical saws and removing an entire full-thickness chunk of the jaw arch, or sometimes amputating half of the entire lower jawbone.
Wow.
This is an absolute necessity if the cancer is deeply embedded, or if the patient presents with what the text graphically calls a pipe stem mandible.
A pipe stem mandible, what is that?
This occurs when the bone has been so severely eroded by an advanced tumor, or hollowed out by previous radiation therapy, that the remaining jawbone is as thin, brittle, and fragile as the stem of a smoking pipe.
The text also details an even more aggressive variation of bone removal called the bite excision. The name is chillingly literal.
Very literal.
If a tumor in that back retromolar trigoni has spread vertically, crawling up into the roof of the mouth and down into the floor, the surgeon doesn't just shave a margin. They remove a piece of the upper gums, the lower gums, and all of the cheek tissue connecting them simultaneously. It is a little bite taken out of the skull to encircle the cancer and ensure clean margins.
The terminology is real because the necessity is real. In these deep, complex spaces of the head and neck, local recurrence, a tumor growing back from a few missed microscopic cells, is incredibly difficult to treat and often fatal.
So we had to get it all.
The surgeon must take enough tissue the first time, but, as radical and destructive as this resection phase is, the operation is only half over.
Right, you have successfully removed the cancer, the margins are clear, but you cannot simply wake a human being up with half their jaw missing grimacing at a gaping hole in the side of their face.
No, you absolutely cannot.
The surgical team now has to pivot entirely from destruction to creation. They have to rebuild the facial structure to restore the patient's identity and their physical ability to interact with the world.
And the text forces us to look at the terrifying alternative to proper reconstruction.
Which is?
If a surgeon removes the entire front arch of the lower jaw, the chin, and the central bone and fails to reconstruct it, the patient suffers from a profoundly debilitating condition, clinically termed the Andy Gump deformity.
Named after an old comic strip character drawn without a lower jaw. It's a very striking, grim visual term.
The physical reality of it is agonizing. Without that anterior mandibular arch, the structural anchor for the entire lower face is gone.
So what happens?
The patient physically loses their chin. Their lower lip collapses, meaning they cannot close their mouth or retain saliva. Most critically, the tongue loses its forward bony attachment.
Oh, that sounds dangerous.
It is. Without that anterior anchor, the tongue falls backward into the throat, severely obstructing the airway and making the basic acts of swallowing or articulating speed a daily nightmare.
So to prevent that total collapse of function, the reconstructive surgeons perform absolute marvels of bioengineering. They use what are called free flaps.
Right.
They need to rebuild a missing jawbone. They perform a free fibular flap, literally cutting a segment of bone out of the patient's leg, shaping it into a new curved jawbone, and using microscopic stitches to connect the tiny blood vessels of the leg bone directly to the arteries in the neck, so the transplanted bone stays alive in the face.
It is microsurgical brilliance, but frequently the primary defect isn't just bone. Think back to the massive cheek flap and the deep muscle resection.
Right.
If the surgeons had to remove a massive volume of the inner cheek, the buccinator muscle, and the deep soft tissue, they have to replace that exact volume. Sometimes for smaller holes, they use a buccal fat pad flap, pulling a deposit of fat from the deep back of the cheek to plug the defect.
Okay.
But for massive soft tissue deficits, they rely on the absolute workhorse of head and neck reconstruction, the pectoralis major flap.
Here's where it gets really interesting. I need to stop you there because when I read this section, my brain short-circuited. Are you saying they detach a chest muscle, the pectoralis major, meant for pushing your arms, leave the blood vessels attached like a garden hose, and physically snake it under the skin of the neck to plug a hole in the cheek?
It sounds like pure science fiction, but it is a highly reliable, life-saving reality.
That is insane.
The reason this specific muscle works so perfectly brings us right back to the vascular logic we keep returning to. The pectoralis major has a massive, highly robust blood supply. More importantly, it is fed by a very long pedicle.
The pedicle being the anatomical leash of blood vessels.
Correct. The artery and vein feeding that chest muscle are long and structurally strong. Surgeons can cut a paddle of muscle and skin free from the chest wall, keep it tethered to its primary blood vessel leash, and physically tunnel that entire massive tissue up under the skin of the collarbone and neck, routing it all the way up into the face.
It's routing it under the skin.
Yeah. They then sew that chest muscle directly into the cheek defect. The text highlights that this flap is incredibly resilient, making it especially crucial for elderly or frail patients who simply might not survive a 12-hour microscopic surgery to connect tiny leg vessels. The chest flap is faster, robust, and dependable.
And the ultimate goal of all this unbelievable biological recycling, the leg bones, the chest muscles, the fat pads, isn't cosmetic, right? It isn't just closing a hole so the face looks okay. It is raw, functional survival.
Function is the prime directive, yes. The text emphasizes a critical consequence of poor reconstruction: scar contracture.
What happens with that?
Well, if a surgeon just sews a large cheek defect closed by pulling the remaining tissue tightly together, that tissue will inevitably form dense, rigid scar tissue as it heals. Scars contract and shrink.
Right.
This leads us right back to where we started, trismus. The patient will have survived the cancer, but the resulting scar tissue will weld their jaw permanently shut.
Oh, wow.
By bringing in large volumes of supple, healthy tissue from the chest or arm, the reconstructive flaps prevent that crippling scar contracture. They provide flexibility needed for the patient to open their mouth, chew their food, and speak clearly.
It's a staggering journey of medical engineering. We started by looking at how the mechanical friction of chewing betel net in South Asia physically breaks down the cheek barrier, inviting cancer in. We saw how a simple pocket of air in a puff cheek CT scan unveils hidden tumors deep in the skull base.
Right.
We learned why splitting a lip down the middle to reach a corner tumor will choke off the water main and kill the tissue, and why a square bone cut will shatter a jaw under the sheer mechanical force of a human bite. And finally, the awe-inspiring reality of tunneling chest muscles up through the neck to rebuild a functional, recognizable human face.
It's incredible.
Every single cut, every single stiff described in this text is a calculated manipulation of life, function, and physical form.
It truly is a symphony of applied anatomy. But, reading through these intensely invasive open surgical procedures, the lip splits, the bone saws, the harvesting of leg bones and chest muscles, it forces us to consider the horizon of oncology.
Oh, for sure.
With the rapidly advancing fields of targeted immunotherapy, which trains the body's own immune system to recognize and dissolve tumors from the inside out, or the ongoing development of microscopic surgical robotics that can navigate these hidden deep spaces through natural orifices without making a single external incision.
It raises a big question.
It does. It raises a profound question. How long until these massive, life-altering facial reconstructions become obsolete? Will there come a day, perhaps in our lifetimes, when medical students look back at the idea of sawing through a jawbone or tunneling a chest muscle to cure buccal cancer the exact same way we look at medieval bloodletting today?
That is a wild, incredible thought to leave on. The idea that this entire meticulously detailed surgical manual, a masterpiece of modern medicine, might one day be a historical relic replaced by a microscopic targeted treatment. It just goes to show how fast the frontier of medicine is moving and how incredibly resilient the human body and the human mind trait to heal it truly is. Thank you for joining us on this deep dive. Keep questioning the incredible mechanics of the human body, and we'll see you next time.